Dr. Richard Morrison had performed over 3,000 surgeries in his career, but something about the new first-year resident scrubbing beside him at 5:47 a.m. made him pause mid-wash. Her hands moved across the surgical sink with deliberate precision, following a pattern he'd seen somewhere before. Not the standard medical school technique. Something else. "You're the new first year?" Morrison asked, his voice carrying across the prep room. "Dr. Vasquez, correct?" Elena Vasquez looked up briefly, dark eyes meeting his through the observation window. "Yes, Dr. Morrison." He studied her hands again as she worked the antimicrobial soap between her fingers. The movements were too practiced, too economical. Each motion had purpose, no wasted energy. Her posture was unnaturally straight, shoulders squared in a way that reminded him of something he couldn't quite place. "Your hands look practiced," Morrison continued, his tone edged with curiosity and skepticism. "Too practiced for someone fresh out of residency. Where did you complete your medical training?" Elena maintained her focus on the scrub protocol. "Johns Hopkins, Dr. Morrison. I take preparation seriously." The answer was textbook perfect, but it didn't explain what Morrison was observing. He'd trained dozens of first-year residents. None of them moved like this. Her technique suggested muscle memory developed over years, not months of clinical rotations. Through the glass, he could see the surgical team prepping OR3 for what should have been a routine cholecystectomy. Standard gallbladder removal, straightforward case. Perfect for a new resident to observe and learn. But Morrison found himself wondering if observation was all Dr. Vasquez needed. Elena finished her scrub and moved toward the operating room, pulling her surgical mask into place with the same efficient movement. Morrison noticed a thin white scar on her right forearm as her sleeve rode up briefly. Old injury. Healed years ago. The kind of scar that came from something sharp and unexpected. Inside OR3, the surgical team stood ready. The scrub nurse had arranged the instrument trays in standard configuration, but Elena's eyes tracked across them with an assessment that seemed almost tactical. Her gaze lingered for a moment on the forceps positioning before she looked away. Dr. Amy Chen, a third-year resident assisting on the case, watched Elena with quiet interest. She'd been in the hospital lounge 2 days ago when the other residents were discussing the new first year who barely spoke to anyone. The resident who somehow knew more about trauma protocols than anyone expected. "Dr. Vasquez will be observing today," Morrison announced to the team. "Standard cholecystectomy, Mrs. Patterson, 58 years old, symptomatic cholelithiasis." Elena nodded, positioning herself where she could see the surgical field without interfering. But her stance wasn't passive observation. She stood ready, weight balanced, hands loosely at her sides. The posture of someone prepared to move quickly if needed. Morrison made his initial incision, working methodically through the layers. The procedure was routine, textbook standard. He'd performed hundreds of these. But as he exposed the surgical field, something felt wrong. The tissue coloring wasn't quite right. "Dr. Vasquez," he said without looking up, "what would you expect to see in standard cholecystectitis?" Elena's response was immediate. Inflammation of the gallbladder wall, possible distension, surrounding tissue edema consistent with acute infection. "And what do you observe here?" There was a pause. Elena stepped slightly closer, her eyes scanning the exposed tissue with intensity that made Morrison's own assessment feel inadequate. When she spoke, her voice carried a certainty that shouldn't exist in a first-year resident. "This isn't standard cholecystitis, Dr. Morrison. Look at the adhesion pattern around the gallbladder fundus. That scarring is consistent with penetrating trauma, healed but creating complications. The inflammation pattern suggests this is a chronic condition triggered by old injury, not acute infection." Morrison's hand stilled. He looked more carefully at what she was describing. The adhesions were there, exactly as she'd indicated. The pattern was unusual, something he'd almost missed in his routine approach. "That's impossible to diagnose without opening the abdomen," Morrison said slowly, but his tone had shifted from skeptical to intrigued. "How did you identify penetrating trauma from external presentation?" Elena's expression remained neutral behind her mask. Patient history indicated previous abdominal pain. The pattern suggested exploration beyond standard diagnosis. It was a non-answer, and Morrison knew it. But the surgical field in front of him told a different story than the one in the patient's chart. Dr. Vasquez had identified something significant, something that would change their entire approach to this procedure. Dr. Chen caught Elena's eye across the operating table. Her expression asked the question Morrison wasn't yet voicing. How did you know that? The wall clock read 5:53 a.m. The surgery that should have been routine had just become considerably more complex. And the first-year resident who shouldn't possess this level of diagnostic skill had just demonstrated something that would make everyone in OR3 start asking questions. Morrison adjusted his approach, working more carefully around the adhesions Elena had identified. His mind was already moving beyond the immediate procedure to larger questions. Questions about the quiet resident who moved with military precision, who saw patterns in tissue that experienced surgeons might miss, whose hands suggested years of practice she shouldn't yet possess. If you want to see how Dr. Vasquez shocks the entire surgical team with skills that shouldn't exist in a first-year resident, make sure you subscribe to Emergency Heroes Stories. Because what happens in the next 40 minutes will redefine everything you thought you knew about combat medicine. Where are you watching from? Because the case that seemed straightforward was about to reveal complications that would force Elena Vasquez to show exactly how different her hands really were. Part 2. The residence lounge at Metropolitan General buzzed with the usual morning energy at 6:23 a.m. Coffee machines hissed, voices overlapped, and exhausted surgical residents tried to caffeinate themselves into alertness before rounds. Doctor. Amy Chen sat in the corner booth, watching two second-year residents dissect the morning's cases with the casual arrogance that came from surviving their first year. Did you see Vasquez in OR3 this morning? The taller resident, Marcus Webb, poured his third cup of coffee. Morrison actually listened to her diagnosis, a first-year calling out adhesion patterns nobody else caught. His companion, Jennifer Park, rolled her eyes. She probably spent all night memorizing surgical atlases. You know the type. Book smart, zero practical experience trying to compensate by over-preparing. Amy stirred her coffee slowly, saying nothing. She'd been watching Elena Vasquez for 3 weeks now. The way she moved through the hospital wasn't like other first years. There was no hesitation, no constant checking of reference materials, no wide-eyed panic during emergencies, just quiet competence that shouldn't exist yet. Nobody learns diagnostic patterns like that from textbooks, Amy said quietly. Marcus laughed. Come on, Chen. You defending the mystery resident? She barely talks to anyone. Keeps her head down, does her work, disappears. It's weird. Maybe she's just focused, Amy suggested. Or maybe she's hiding something, Jennifer added. I heard Morrison asking surgical staff about her yesterday. Apparently her technique in that cholecystectomy was too refined. He thinks she might have undisclosed prior surgical experience. The conversation shifted as other residents joined the table, but Amy's mind stayed on Elena. The scars she'd glimpsed on Elena's forearms during a procedure last week. The way Elena's posture straightened whenever overhead announcements mentioned trauma alerts. The subtle assessment she made of every room she entered, like she was calculating exits and threats. 20 minutes later, morning rounds began. Dr. Taham. Morrison led the procession through the surgical ward, a dozen residents trailing behind like exhausted ducklings. He stopped at each patient room, firing questions designed to expose gaps in knowledge and preparation. When they reached Mrs. Patterson's room, the cholecystectomy patient from earlier, Morrison turned to face his residents. His eyes found Elena at the back of the group. Dr. Vasquez, perhaps you can explain to your colleagues how you identified penetrating trauma from preoperative assessment, since your diagnosis this morning was so remarkably accurate. The other residents turned to look. Elena maintained her neutral expression, but Amy noticed the slight tension in her shoulders. Patient history indicated previous abdominal surgery, Elena said simply. The scar tissue pattern suggested trauma rather than elective procedure. And you determined this how? Morrison pressed. His tone wasn't hostile, but it carried weight. The patient's chart made no mention of previous trauma. The physical examination revealed indicators consistent with old injury. Scar tissue creates distinctive patterns. Morrison's expression shifted into something that looked like amusement. This isn't a field hospital, doctor. We have comprehensive imaging, detailed patient histories, and time to make proper diagnoses. We don't rely on tactical assessments and battlefield medicine. Several residents laughed, Elena said nothing, but Amy saw her jaw tighten almost imperceptibly. In civilian medicine, Morrison continued, his voice carrying that particular tone senior physicians used when teaching through humiliation, we follow established protocols. We don't make dramatic diagnostic leaps based on intuition. Is that clear? Yes, Dr. Morrison. The rounds continued, but the damage was done. By the time they reached the surgical planning room, Amy heard at least 3 residents speculating about whether Vasquez had fabricated her diagnosis to seem impressive. The consensus was forming. She'd gotten lucky, nothing more. At 7:14 a.m., Elena was assigned to assist on an appendectomy in OR2. Standard case, almost routine. Dr. James Patterson, chief of the emergency department, would be performing the procedure. Elena was designated as first assist, which meant mostly observing and handling retractors. The patient, Michael Rodriguez, was a 45-year-old construction worker with classic appendicitis presentation, elevated white blood cell count, McBurney's point tenderness, fever. Textbook symptoms that any first year could recognize. Patterson was known for running efficient surgeries with minimal conversation. He worked methodically, explaining steps as he went for the benefit of residents, but not encouraging questions or input. The perfect assignment for a first year meant to observe and learn. Elena scrubbed in with the same precise movements Amy had noticed before. Through the observation gallery, Amy watched as Elena positioned herself at the operating table. Patterson made his initial incision, working through the abdominal layers with practiced ease, but then Elena's posture changed. She leaned slightly forward, her focus intensifying on something Amy couldn't identify from her vantage point. Dr. Patterson, Elena said quietly. The peritoneal fluid. Patterson glanced up. What about it? The odor. That's not standard inflammatory response. Patterson paused, actually looking at her now. Dr. Vasquez, olfactory diagnosis isn't standard practice. We have laboratory tests for bacterial identification. This is perforated with septic peritonitis, Elena continued, her voice carrying more certainty than a first year should possess. We need to extend the incision and prepare for significant contamination. That's a considerable assumption based on subjective observation, Patterson said, but his hands had slowed. He was considering what she'd said. With respect, doctor, the presentation pattern and fluid characteristics indicate perforation. If I'm correct, standard appendectomy approach won't be sufficient. The OR went quiet. Amy leaned forward in the observation gallery. Patterson studied the surgical field more carefully, then made a small extension to his incision for better visualization. When he exposed the appendix fully, his expression changed. The organ was indeed perforated, with significant peritoneal contamination exactly as Elena had predicted. The straightforward appendectomy had just become a complex cleanup procedure. How did you know that before visualization? Patterson asked, his tone shifting from dismissive to genuinely curious. Elena's response was careful. Pattern recognition, Dr. Patterson. The symptoms suggested a more advanced condition than initial assessment indicated. Amy watched from above as Patterson adjusted his entire surgical approach. He was looking at Elena differently now, the way Morrison had looked at her during rounds, with questions he wasn't quite ready to ask. The wall clock showed 7:34 a.m. What should have been a 45-minute procedure was about to take significantly longer. And the first-year resident who somehow knew too much was once again demonstrating knowledge that didn't match her supposed experience level. In the observation gallery, Amy pulled out her phone and made a note. Third time in 3 weeks that Vasquez had identified complications others missed. Not lucky guesses. Something else. Something that made Amy think of the military physicians she'd worked with during her rotations, the ones who'd seen trauma patterns that civilian medicine rarely encountered. She made a mental note to look more carefully at Elena Vasquez's background, because someone who could diagnose like that had learned somewhere other than medical school. Part 3. Patterson's hands moved with controlled urgency once he recognized the perforation. The routine appendectomy had transformed into something considerably more complex. Septic peritonitis required immediate intervention, extensive irrigation, and meticulous technique to prevent complications. Suction, he commanded, and the scrub nurse responded instantly. We need better exposure. Retractor. Balfour self-retaining. Elena positioned the retractor without being asked. Her movements synchronized with Patterson's needs before he voiced them. Her hands placed the instrument with precision that made the scrub nurse pause mid-reach for another tool. Irrigation. 1 liter normal saline. Warm. Patterson continued. He glanced at Elena. Dr. Vasquez, you'll close. I want to see your technique. It wasn't a request. It was a test. Elena accepted the needle driver when Patterson handed it to her 30 minutes later. The contaminated tissue had been debrided, the peritoneal cavity thoroughly irrigated. Now came the closure, layer by layer, each suture critical to preventing infection and ensuring proper healing. She positioned her hands over the surgical field, and Dr. Amy Chen, still watching from the observation gallery, leaned forward. This was where technique revealed training, where muscle memory showed its origins. Elena's first suture was a figure-of-8 interrupted stitch, placed with speed that seemed impossible for the level of precision involved. Her fingers moved in a pattern that was economical, practiced, almost rhythmic. No hesitation, no adjustment, no second-guessing. Jesus, the surgical tech whispered to the scrub nurse. Look at that hand position. The sutures continued, each one identical in tension, spacing, and depth. The kind of consistency that came from hundreds of repetitions, not dozens. Elena worked through the fascial layer with what Patterson could only describe as surgical efficiency he'd seen in very few residents, and never in first years. Your technique, Patterson said, not looking up from monitoring the closure. Where did you learn to tie like that? Practice, Dr. Patterson. That's not practice. That's mastery. He watched her complete another suture. Those are combat quick ties, modified for speed without sacrificing holding strength. I've seen them before, but only from military surgeons. Elena's hands didn't pause, but Patterson saw the slight change in her breathing pattern. I studied various techniques during my surgical rotations, she said carefully. The anesthesiologist, Dr. Kumar, had been monitoring vitals with half his attention on the unusual exchange. Her situational awareness is remarkable, he interjected. She knew the patient's blood pressure was dropping before the alarm sounded, twice. Patterson filed that observation away with the growing list of anomalies surrounding Dr. Vasquez. He'd spent 6 years as a Navy physician before transitioning to civilian medicine. He recognized certain patterns, certain behaviors that civilian medical training didn't produce. Elena completed the fascial closure and moved to the subcutaneous layer. Her suturing technique shifted slightly, adapting to the different tissue requirements without anyone telling her to modify her approach. Patterson noticed she was using a modified subcuticular running stitch, the kind designed to minimize scarring while maintaining strength. Time, Patterson said to the room. 38 minutes from complication identification to closure completion. The circulating nurse reported. Patterson checked his watch himself. She was right. What should have been a 90-minute complex case had taken just over half an hour beyond the initial diagnostic phase. Elena's closure work had been completed in less than 12 minutes for multiple layers. That's not possible, the surgical tech muttered. But the monitor showed stable vitals. The surgical field showed perfect technique, and the patient was already showing signs of strong recovery. Possible or not, it had happened. Patterson studied Elena as she removed her gloves with the same efficient movements she'd displayed throughout the procedure. No celebration, no acknowledgement of what she'd just accomplished. Just quiet competence and immediate readiness to move to whatever came next. Dr. Vasquez, those sutures were flawless, Patterson said. Your technique suggests considerably more experience than a first-year resident should possess. I prepared extensively during medical school, Dr. Patterson. Preparation doesn't create muscle memory like that. He stripped off his own gloves. I trained military physicians for 3 years. Your hand position, your suturing pattern, your stress response. That's combat medicine training. Elena met his gaze steadily. Is there anything else you need, doctor? I should check on my other assigned patients. Patterson recognized the deflection. He'd used similar tactics himself when asked about his Navy service in professional settings where military background complicated civilian interactions. Patient is stable, he said. Prognosis is excellent. You can break scrub. Elena nodded and moved toward the scrub sink. Through the observation window, Amy Chen was already pulling out her phone, making notes. The second-year residents who'd been discussing Elena in the lounge that morning were now watching with expressions that ranged from confusion to grudging respect. In the hallway outside OR2, Dr. Morrison stood with a surgery schedule in his hands, but his attention was fixed on the observation window. He'd watched the last 15 minutes of Elena's closure work, watched her hands move with precision that shouldn't exist in someone 3 weeks into their residency. Patterson emerged from the OR to find Morrison waiting. "You saw," Patterson said. It wasn't a question. "I saw." Morrison's expression was thoughtful. "That's the second time today she's demonstrated skills that don't match her file. The cholecystectomy this morning, now this. She's had advanced training somewhere. Combat medicine. Maybe field hospital experience. The patterns are unmistakable." Morrison pulled up Elena's file on his tablet. Johns Hopkins Medical School. Excellent grades. Standard surgical rotations. Nothing unusual in her official record. But records didn't always tell complete stories. "I'm going to talk to her," Morrison said. "This afternoon. Because whoever Dr. Elena Vasquez really is, she's not just a first-year resident learning basic technique." The wall clock showed 8:12 a.m. The hospital was fully awake now. Emergency department filling with morning cases. Surgical schedules ramping up to full capacity. And somewhere in the building, a first-year resident who'd just completed perfect surgery in impossible time was trying very hard to remain invisible. But invisibility, Morrison reflected, became significantly harder when your hands performed miracles that demanded explanation. Elena Vasquez could deflect questions, could offer careful non-answers, could maintain her quiet competence. What she couldn't do was hide what her hands revealed every time she touched a patient. And those hands, Morrison was becoming certain, had stories that Johns Hopkins Medical School had never taught. The question was whether Elena would tell those stories willingly, or whether circumstances would force the truth into the open before she was ready to share it. Part 4. The overhead speakers crackled to life at 9:47 a.m., interrupting the relative calm that had settled over Metropolitan General's surgical floor. The automated voice carried urgency that made every medical professional within earshot stop what they were doing. "Trauma alert. Multiple casualties. MVA on I-90 with entrapment. 6 critical incoming. ETA 4 minutes. All available surgical staff report to emergency department immediately. Repeat. Trauma alert. Multiple casualties. ETA 4 minutes." Elena Vasquez was reviewing post-operative orders at the nurses' station when the announcement came. Her body's response was automatic, instantaneous. Shoulders squared, breathing deepened, mental triage protocols activating before conscious thought. She caught herself, forced relaxation back into her posture, but not before Dr. Amy Chen noticed the shift. The emergency department transformed within seconds. Trauma bays that had been processing routine cases suddenly cleared. Nurses wheeled equipment into position. Residents appeared from various floors, pulled by the magnetic urgency of mass casualty response, the organized chaos of a Level 1 trauma center preparing for the worst. Dr. Patterson stood at the command station, radio crackling with updates from incoming ambulances. His expression was grim as he listened to the preliminary reports. "First ambulance 2 minutes out," he announced to the assembling team. "Male, late 20s, GSW to chest, tension pneumothorax, BP dropping. Second ambulance has female, 30s, steering wheel impact, probable cardiac contusion, possible internal bleeding. Third ambulance is bringing military personnel, blast pattern injuries." Elena's head snapped up at blast pattern injuries. Patterson noticed, filed that reaction away with all his other observations about Dr. Vasquez. "4th through 6th ambulances have various trauma," Patterson continued. "We're running this by standard mass casualty protocols. Morrison, you take Trauma Bay 1. Chen, Bay 2. Vasquez, you're on Bay 3 with the cardiac case." But Elena was already looking past him, toward the ambulance bay doors. Her eyes had that distant focus Patterson recognized from military physicians, anticipating combat casualties. The first ambulance screeched into the bay. Paramedics exploded from the vehicle, wheeling the gurney at controlled sprint speed. "Male, 29, GSW to left chest. Entrance wound second intercostal space." The lead paramedic rattled off. "Breath sounds absent on left. Suspected tension pneumothorax. 2 large bore IVs established. pressure 80/40 and dropping. Morrison took control immediately, his team surrounding the patient with practiced efficiency. The trauma bay became a controlled storm of activity. The second ambulance arrived 30 seconds later. Elena moved toward trauma bay 2 as directed, but her attention kept pulling toward the approaching third ambulance. Something in her expression made Patterson pause. The third ambulance backed into position. Before the doors opened, Elena could see the paramedic inside, his face reflecting an intensity that spoke of something beyond standard trauma. When they pulled the gurney out, she saw why. The patient wore remnants of combat fatigues. His injuries showed the distinctive pattern of IED fragmentation, multiple penetrating wounds, burns consistent with blast exposure, the kind of trauma signature Elena had seen hundreds of times in field hospitals thousands of miles from Chicago. And then the patient's eyes flickered open, found her face through the crowd of medical personnel, and recognition sparked despite his pain-clouded consciousness. "Doc Vasquez?" His voice was barely audible, but in the chaos of the ED, somehow Elena heard it clearly. Patterson was at her shoulder. "You know this patient?" Elena started, then the patient spoke again. "Doc Vasquez. Kandahar. 2021. You saved." His voice faded as consciousness slipped. The paramedic looked between Elena and the patient, confusion evident. "He's been semi-conscious since we pulled him from the vehicle," the paramedic explained. "Name's Captain Mark Torres, U.S. Army Rangers. His wallet had military ID. He kept asking for a doctor named Vasquez." Patterson studied Elena's face. Her professional mask was cracking, revealing something underneath that looked like recognition, guilt, and a desperate need to help all mixed together. "Bay 3 can wait," Elena said, her voice carrying new authority. "Captain Torres needs immediate assessment. Those injuries are consistent with retained shrapnel complications. If I'm right, he's at risk for fragment migration and internal hemorrhaging. How can you possibly know that from—" Patterson began, but Elena was already moving toward Torres's gurney. "Because I've seen this exact pattern before," she said, and Patterson heard the edge in her voice that suggested she'd seen it many times before. Dr. Morrison appeared from Trauma Bay 1, having stabilized his GSW patient enough to hand off to surgery. He caught the tail end of the exchange, saw Elena's intensity, heard Torres murmuring her name. "Dr. Vasquez." Morrison's voice cut through the noise. "Explain how a first-year resident knows a military patient with blast injuries from 2021. Elena looked at Morrison, then at Patterson, then at Captain Torres, who was deteriorating on the gurney in front of her. The decision played across her face in the space between heartbeats. "I can explain later, Dr. Morrison," she said. "Right now, Captain Torres needs someone who understands his injury pattern. He has retained IED fragments near major vessels, probably from a 2021 mission in Kandahar. Standard trauma protocols won't account for metal that's been shifting inside his body for 4 years. The ED had gone quiet around them. Other residents, nurses, attending physicians, all processing what Elena had just revealed without explicitly stating. Morrison's eyes narrowed. "You're military." It wasn't a question. "I was military," Elena corrected. "And right now, that might be the only thing that keeps Captain Torres alive. So I'm asking permission to lead his trauma assessment, because I've treated these exact injuries before, in conditions much worse than this." Patterson looked at Morrison. Morrison looked at Torres, whose vitals were declining rapidly on the monitor. Whatever questions needed answering, they could wait until after the immediate crisis. "You've got him," Morrison decided. "But after this, you and I are having a very long conversation about your background." Elena nodded once and turned to Torres's trauma team. Her voice shifted, taking on tones of command that shouldn't exist in a first-year resident, but felt completely natural coming from her. "Get me portable ultrasound, full trauma panel, and prep OR1 immediately. We need to map the fragment locations before we move him. Chen, I need you on this case. Patterson, I could use your experience with military trauma." Within 2 minutes, Trauma Bay 3 was a controlled storm of activity centered around Captain Torres. Elena worked with focused intensity, hands moving across the ultrasound probe like she'd performed this assessment countless times before. Because she had. By 10:05 a.m., Torres had been stabilized enough for transport to surgery. The other 5 trauma patients were similarly being processed through the ED's machinery of emergency care. But the questions hanging in the air around Elena Vasquez had multiplied exponentially. Dr. Amy Chen stood beside her as they prepped for Torres's transfer upstairs. "You were in the military," Chen said quietly. "Combat medicine?" Elena met her eyes. "Yes." "For how long?" 7 years. Forward surgical teams, field hospitals, FOBs across Afghanistan and Iraq. Chen absorbed that information. "That's why your techniques are so advanced. You're not learning. You're remembering." "Something like that," Elena agreed. The wall clock showed 10:08 a.m. Captain Torres was being wheeled toward the elevator, Elena and Patterson flanking his gurney. Morrison watched them go, his mind racing through implications and questions that would require answers soon. But first, there was a patient to save. A patient who'd called Elena's name in his delirium, who'd recognized her, despite 4 years and thousands of miles separating their last encounter. A patient whose life now depended on skills Elena had been trying very hard to keep hidden. Part 5. Morrison's office felt smaller than usual at 10:17 a.m. The chief of surgery stood with his back to the window, arms crossed, watching Elena Vasquez with an expression that mixed curiosity, frustration, and growing certainty. Patterson leaned against the doorframe, blocking the exit. Not threatening, but making it clear this conversation was happening. "Dr. Vasquez," Morrison began, his tone carefully controlled. "That patient downstairs, Captain Torres, he knows you. He specifically asked for you, by name." Elena kept her expression neutral. "Patients sometimes remember physicians from previous encounters." "Previous encounters," Morrison repeated. "The man has been semi-conscious since his accident. Yet somehow, through the fog of trauma and pain medication, he recognized you, called you Doc Vasquez, referenced Kandahar and 2021. Patterson spoke from the doorway. "I've been watching you for 3 weeks now, Elena. Your surgical technique this morning wasn't learned in civilian rotations. Your suturing patterns are combat quick ties. Your diagnostic approach assesses threats and priorities like field triage. You move through this hospital like you're scanning for tactical situations." Elena's jaw tightened almost imperceptibly. "I take my training seriously, Dr. Patterson." "This isn't about training," Morrison cut in. His voice carried weight now, the authority of someone who'd spent 30 years reading people as well as medical charts. 3 weeks ago, you walked into this hospital as a first-year resident. But your hands perform surgery like someone with years of experience. You identify complications before imaging confirms them. You recognize blast injury patterns that civilian physicians rarely see. He moved closer, studying her face. "And now a military patient calls your name in delirium, referencing Afghanistan in 2021. So I'm going to ask you directly, Dr. Vasquez. Where did you really learn to practice medicine?" Elena met his gaze steadily. The silence stretched between them, filled with unspoken truths and calculations about what revealing those truths might cost. "I completed my medical training at Johns Hopkins," she said carefully. "All my credentials are in order." "Your credentials are impeccable," Morrison agreed. "What they don't explain is why you perform like a surgeon who's spent years in combat zones." "Military medicine, Elena. That's what we're seeing. Patterson recognizes it because he trained Navy physicians. I recognize it because I lost my son in a vehicle accident 3 years ago. And the trauma surgeon who tried to save him had the same look in his eyes that you have. The look of someone who's made life and death decisions under impossible conditions." Elena's composure cracked slightly at the mention of Morrison's son. "I'm sorry for your loss, Dr. Morrison." "Don't deflect," he said, not unkindly. "Captain Torres is downstairs deteriorating. You said he has retained IED fragments near major vessels. You said standard protocols won't account for metal that's been shifting for 4 years. How do you know that?" Before Elena could answer, her pager shrieked. The code was unmistakable. Trauma Bay 3. Captain Torres. Critical. Patterson's radio crackled simultaneously. "Dr. Patterson to Trauma 3 immediately. Patient Torres is coding. We need surgical intervention now." Elena was already moving toward the door. Morrison stepped in front of her. "Answer the question first," he demanded. "Who are you really?" Elena looked at him, then at Patterson, then at the pager still buzzing in her hand. Her carefully maintained facade was crumbling, and they all knew it. The question was whether she'd let it fall completely, or keep trying to hold the pieces together. "I'm a surgeon," she said finally. "I'm someone who can save Captain Torres's life right now, if you let me get to that trauma bay. We can discuss my background after I prevent a good man from dying on your operating table." Morrison held her gaze for 3 more seconds, then stepped aside. Elena sprinted down the hallway, Patterson close behind. Morrison followed at a controlled pace, pulling out his phone to call security for Elena's full personnel file. Whatever secrets Dr. Vasquez was keeping, they were about to come into the open whether she wanted them to or not. Trauma Bay 3 was controlled chaos when Elena burst through the doors. Captain Torres lay on the gurney, monitors screaming, residents performing CPR with increasing desperation. "He crashed 2 minutes ago," Dr. Chen reported, not breaking rhythm on chest compressions. "VFib, not responding to defibrillation. We've tried 2 rounds of EPI." Elena scanned the monitors, the patient's positioning, the readouts from the portable ultrasound they'd done earlier. Her mind processed information with speed that came from hundreds of similar situations in much worse conditions. "Stop compressions," she ordered. "What?" Chen looked up, confused. "He'll die. He's dying anyway if we don't address the actual problem." Elena moved to the ultrasound machine, pulling up the images they'd captured before. "Look at this fragment here, near the left ventricle." The crash impact shifted it. "Every compression you do is driving it closer to puncturing his cardiac wall." Patterson was beside her now, studying the image. "She's right. That fragment's moved 3 millimeters since the initial scan." "Then what do we do?" Chen asked. "We can't just stop trying." Elena's hands were already moving, positioning Torres differently on the gurney, adjusting his angle to redistribute pressure around the fragment location. It was a technique she'd learned in a tent hospital outside Kandahar, when traditional positioning would have killed a soldier with similar injuries. "Resume compressions at this angle," she directed. "Modified positioning to avoid direct pressure on the fragment site. Chen, I need you to prep for emergency pericardiocentesis. We're going to drain the tamponade that's developing around that fragment." Morrison arrived in time to hear the last instruction. "Dr. Vasquez, pericardiocentesis isn't a resident procedure. That requires... I've performed 47 pericardiocentesis procedures under combat conditions." Elena interrupted, her voice carrying authority that silenced objections. "Captain Torres has cardiac tamponade developing from fragment shift. If we don't drain it in the next 90 seconds, he dies. I can do this. I've done it before. Multiple times." The room went silent except for the monitors. Everyone was looking at Elena, seeing her clearly for the first time. Not a first-year resident tentatively learning procedures. A combat surgeon speaking with the certainty that came from saving lives when failure meant watching soldiers die. Morrison made his decision. Do it. Elena's training took over completely. The civilian hospital fell away, replaced by muscle memory from field hospitals, where every second mattered, and hesitation meant death. Her hands moved with practiced precision as she positioned the ultrasound probe, identified the optimal insertion point, prepped the site with efficiency that came from performing procedures in minutes instead of the hours civilian medicine allowed. 18-gauge spinal needle, she called out, and Chen placed it in her hand without question. Attach EKG lead to needle hub. Watch for ventricular capture on the monitor. Patterson positioned himself where he could see both Elena's hands and the ultrasound screen. He'd watched military physicians work before, but Elena's technique was something beyond standard combat medicine. This was expertise honed by repeated necessity, refined by experience most physicians never accumulated in entire careers. Elena inserted the needle at a 30-degree angle toward Torres's left shoulder, advancing slowly while monitoring the ultrasound guidance. The room held its breath. One wrong move and she'd puncture his heart instead of draining the fluid compressing it. The needle entered the pericardial space. Dark blood appeared in the syringe as Elena began aspirating. The monitors showed immediate response. Torres's cardiac rhythm began organizing, pressure redistributing as the tamponade released. 80 milliliters, Elena reported, continuing the aspiration. 120, 160, pressure's equalizing. On the monitor, Torres's heart rhythm strengthened. The chaotic V-fib pattern resolved into something more organized. His blood pressure began climbing from critical levels toward something survivable. Elena finished the aspiration at 180 milliliters, removed the needle with the same controlled precision, and applied pressure to the insertion site. The entire procedure had taken less than 3 minutes. Captain Torres's eyes flickered open. His gaze found Elena's face, and recognition sparked despite the medication clouding his consciousness. "Doc Vasquez," he whispered, "knew you'd save me again." The trauma bay erupted in controlled activity as the team stabilized Torres for transport to surgery. But Morrison stood at the back of the room, watching Elena work with hands that had just performed a procedure most civilian physicians attempted maybe once or twice in their entire careers. Patterson moved beside him. "She's military trained," he said quietly. "Combat surgery, forward operating base experience. That wasn't textbook technique. That was battlefield medicine adapted for civilian setting." Morrison nodded slowly. 7 years, she said. 7 years of combat medicine. That's why her hands are different. Elena was removing her gloves, her focus already shifting to Torres's transfer protocols. But she looked up, met Morrison's eyes across the trauma bay, and in that moment, the last of her carefully constructed anonymity fell away. Part 6. Morrison stood in the OR prep room at 10:21 a.m., watching Elena scrub with an intensity that suggested she was preparing for war, not surgery. Patterson was beside him, both men understanding they were about to witness something that would redefine their understanding of the resident they'd been underestimating for 3 weeks. "Before we go in there," Morrison said quietly, "I need to know exactly who you are, Dr. Vasquez. Not speculation, truth. Because I'm about to let you lead a procedure that could kill Captain Torres if you're wrong about your abilities." Elena turned from the sink, water dripping from her forearms. The professional mask she'd maintained so carefully had finally fallen away completely, revealing something underneath that Morrison hadn't seen in civilian medicine. Certainty forged by experience, most physicians never accumulated. "Major Elena Vasquez," she said, her voice carrying the weight of admission that would change everything. U.S. Army Medical Corps, 2015 to 2022. 7 years assigned to forward surgical teams in Kandahar, Mosul, Baghdad, and 3 other classified locations. 832 combat surgeries performed under fire. 47 emergency pericardiocentesis procedures in field conditions with survival rates that exceeded predicted outcomes by 33%. The prep room went silent, except for the sound of running water. Dr. Chen, who'd been scrubbing beside Elena, stared with her hands frozen mid-wash. "I received 3 Bronze Stars and 2 Army Commendation Medals for medical valor," Elena continued. "I led trauma teams in mass casualty situations, where we had 15 minutes and limited supplies to decide who lived and who died. Captain Torres was my patient in August 2021, Kandahar Province. IED blast killed 3 members of his squad. I operated on him for 6 hours with mortar fire landing within 50 meters of our position." Morrison processed this information against everything he'd observed. The pieces finally aligned into a picture that made horrifying sense. "You left in 2022, he said. 3 years ago. You could have gone anywhere. Why hide this? Why present yourself as a first-year resident?" Elena's expression shifted, revealing pain beneath the professional competence. "Because I wanted to learn civilian medicine without people making assumptions about what combat experience means. Because I needed to prove I could save lives without the constant pressure of battlefield conditions. Because I was tired of being defined by 7 years of war," Patterson spoke up. "The military trains some of the best trauma surgeons in the world. You should be proud of that experience, not hiding it. Pride isn't the issue," Elena said quietly. "Integration is. Civilian medicine operates differently. I wanted time to adapt without everyone treating me like I was damaged goods from war zones." The overhead intercom interrupted them. "OR 1. Patient Torres is prepped and ready. Surgical team needed immediately." Morrison made his decision. "You'll lead the procedure. Patterson and Chen assist. I'll observe. But Elena, if what you're about to do is as complex as I think it is, I need you to explain every step so we understand how combat medicine translates to civilian practice." Elena nodded once and pushed through the OR doors. Captain Torres lay on the operating table, already under anesthesia. The portable ultrasound screen showed the IED fragments scattered throughout his chest cavity, 3 pieces of metal that had been shifting slowly for 4 years. The largest fragment sat millimeters from his left ventricle, moving with each heartbeat. This is what we call retained fragmentation with progressive migration, Elena explained as she positioned her hands over Torres's chest. In combat zones, we couldn't always remove all the shrapnel. Too dangerous, too unstable. We'd stabilize the patient, evacuate them, and hope military hospitals stateside could handle extraction later. But sometimes the fragments stay, and sometimes they shift. She indicated the largest piece on the ultrasound. That fragment has migrated 7 millimeters in the past 4 years. The crash impact accelerated its movement. If we don't remove it now, it will puncture his ventricular wall within days, maybe hours. Standard cardiothoracic approach won't work because the fragment is embedded in scar tissue from the original injury. So how do we approach this? Chen asked, fascinated despite the gravity of the situation. We use a modified combat extraction technique, Elena said. Scalpel. Her first incision was precise, following pathways that avoided major vessels with certainty that came from performing this exact procedure dozens of times. But this wasn't a tent hospital with improvised lighting and incoming fire. This was a state-of-the-art operating room with every advantage modern medicine could provide. Elena worked through the tissue layers with focused intensity. Retractor. Self-retaining Finocchieto. We need maximum exposure. The surgical field opened, revealing Torres's chest cavity and the intricate network of scar tissue surrounding the fragment locations. Elena's hands moved with practiced efficiency, identifying anatomy through touch as much as sight. The key to fragment extraction is understanding blast mechanics, she continued, teaching even while operating. IED fragmentation doesn't create clean wounds. Metal enters at high velocity, tumbles, creates cavities. Each fragment leaves a signature pattern of damage. If you follow that pattern backward, you can extract without causing additional trauma. Patterson leaned closer, studying her technique. That's not taught in civilian surgical training. It's learned by necessity in combat medicine, Elena agreed. Suction. I need better visualization here. She worked around the first fragment, a smaller piece lodged in the intercostal space. The extraction was smooth, practiced, the kind of procedure that looked simple but required years of experience to perform safely. Fragment 1 secured, she announced, moving to the second location. This one's trickier. It's against the pleural lining. Morrison watched from the observation position, his earlier skepticism completely replaced by professional admiration. Whatever else Elena Vasquez might be, she was unquestionably one of the most skilled surgeons he'd witnessed in 3 decades of medicine. The second fragment extraction took longer, required more delicate manipulation. Elena's hands never wavered, her focus absolute. The monitoring equipment showed stable vitals throughout, testament to her precise technique. Fragment 2 secured. Now the difficult one. The largest piece of shrapnel sat against Torres's left ventricle, embedded in scar tissue that had formed over 4 years. Every heartbeat sent vibrations through the metal, each pulse bringing the fragment marginally closer to catastrophic breach. This is where combat medicine gets creative, Elena said. In field hospitals, we didn't have luxury of perfect conditions. We learned to work with imperfect anatomy, compromised tissue, situations that textbooks said were impossible. Standard protocol says we should stop Torres's heart for this extraction. But stopping his heart with this much scar tissue increases mortality risk by 40%. So, what's the alternative? Chen asked. We work between heartbeats. Ultrasound guidance, synchronized to his cardiac rhythm, extracting during diastole when the ventricle is least vulnerable. It requires timing precision measured in milliseconds. Morrison's hands tightened on the observation rail. What Elena was describing was technically possible, but extraordinarily difficult. The kind of procedure most surgeons wouldn't attempt without extensive preparation and multiple consultations. Elena positioned the extraction forceps, her eyes fixed on the ultrasound monitor showing Torres's heart rhythm. She waited, watching the electrical pattern, timing her movements to the spaces between contractions. Then she moved. The extraction happened so quickly, Morrison almost missed it. One moment, the fragment was embedded against the cardiac wall. The next, Elena's forceps held the piece of twisted metal, removed cleanly without disturbing the surrounding tissue. "Fragment 3 secured," Elena announced, her voice steady despite having just performed something that bordered on surgical impossibility. "Preparing for closure, standard interrupted sutures, reinforced at stress points. He'll need follow-up monitoring for 6 months, but prognosis is excellent. Torres's vitals remain stable throughout. No complications, no bleeding, no signs of cardiac distress. The procedure that could have killed him had instead been executed with precision that made it look routine." As Elena began closing, Patterson spoke quietly to Morrison. "I've seen good surgeons. I've seen great surgeons. What I just watched was mastery developed in conditions most of us can't imagine." Morrison nodded slowly. "The question is what we do with that knowledge now that we have it." Elena completed the closure with the same flawless technique she'd displayed all morning. When she finally stepped back from the table, stripping off her gloves, the OR clock showed 11:18 a.m. The procedure had taken 57 minutes from incision to closure. "Patient is stable," Elena reported. "He should make full recovery. I'll write detailed post-operative orders accounting for his combat injury history." She turned to face Morrison and Patterson, and for the first time since entering the OR, allowed exhaustion to show on her face. Not physical exhaustion, the emotional weight of revealing everything she'd been hiding for 3 weeks. "So now you know," she said quietly. "Major Elena Vasquez, combat surgeon. Trying to learn how to save lives without the constant awareness that mortars might land on the operating room. That's who I am. That's why my hands are different. Because they've held instruments while explosions shook the ground. Because they've sutured wounds while soldiers screamed and ammunition cooked off in burning vehicles nearby. Because they learned to work faster than death could claim the people counting on me to save them." The OR was completely silent. Chen stood with tears in her eyes. Patterson's expression carried understanding and respect. Morrison looked at Elena with something that might have been awe. When combat defines every decision you make, when revealing your truth means accepting that people will always see you through that lens, how do you decide when to stop hiding? What would you have done in Elena's position? Captain Torres's steady heartbeat on the monitor provided the only answer that mattered. A life saved. A soldier who would see his family again. A testament to hands that were different, precisely because they'd learned to perform miracles when miracles were the only option that meant survival. Part 7. Morrison's office felt different at 11:45 a.m. The power dynamic had shifted in ways that went beyond professional hierarchy. Elena sat across from the chief of surgery, still in her scrubs, while Patterson leaned against the wall and Dr. Chen stood near the door. The atmosphere carried weight that hadn't existed 3 hours earlier. "Major Vasquez," Morrison began, then corrected himself. "Dr. Vasquez, I owe you an apology. This morning I mocked your diagnostic approach, dismissed your techniques as inappropriate for civilian medicine. I made assumptions based on your position rather than recognizing your experience." Elena's expression remained neutral, but her posture had changed. She no longer hunched her shoulders trying to appear smaller, less threatening. The military bearing she'd been suppressing for 3 weeks had returned. "I've been practicing surgery for 30 years, Morrison continued. "What I watched you do in that OR was beyond anything I've seen in civilian medicine. The precision, the timing, the adaptation to complex anatomy. That wasn't luck or raw talent. That was mastery earned through experience most physicians never accumulate." Patterson spoke up from his position against the wall. "I spent 6 years training Navy physicians. I recognize combat medicine when I see it. Your technique this morning, Elena, that was battlefield surgery adapted for civilian setting. The question is, what happens now?" Dr. Chen cleared her throat. "The other residents are talking. Word spreading through the hospital about what you did, about who you really are. Some are angry you hid your background. Others want to learn from you. But everyone's confused about why someone with your experience was pretending to be a first-year resident." Elena looked at each of them in turn. "I left the military in 2022, after 7 years of deployment rotations. I came to civilian medicine because I wanted to learn how to save lives without the constant background noise of war, without every decision being colored by resource scarcity, triage protocols designed for mass casualties, and the knowledge that mortars might hit while you're operating. She paused, gathering words for something she'd never articulated before. In Kandahar, 2019, there was a school bombing. 23 children arrived at our field hospital within 15 minutes. We had supplies for maybe 10 complex pediatric cases. I had to choose who to operate on first, who could wait, who we'd lose no matter what we did. Morrison's expression shifted. That's an impossible situation. I saved 20 children that day. Elena continued, her voice tight. 3 died while I was operating on others. For 3 years, I've carried guilt about those 3. About whether I made the right choices, whether different decisions might have saved them. I came to civilian medicine to escape that weight, to learn medicine where I didn't have to make those calculations. Patterson moved closer. Elena, combat triage isn't about wrong choices. It's about impossible choices. You saved 20 out of 23 with resources for 10. That's remarkable. Tell that to the families of the 3 who died, Elena said quietly. Chen stepped forward, pulling out a tablet. Dr. Patterson asked me to look into your military record while you were in surgery. With proper clearance. There's something you need to see. She handed the tablet to Elena. On the screen was a declassified after-action report from the Kandahar school bombing, dated August 2019. Elena's hands trembled slightly as she read. Intelligence knew the attack was coming, Chen explained. They had advanced warning at least 6 hours before the bombing. Your field hospital should have been reinforced, should have received additional supplies and personnel. Instead, Command sent your team with standard equipment to an area they knew would become a mass casualty site. Elena looked up from the tablet, confusion mixing with growing realization. Why would they do that? Patterson took the tablet, scrolled to a different section. Because you were making senior officers look bad. Female surgeon, under 30, earning more commendations than officers with twice your experience. Some people decided you needed to be, quote, brought down to reality about the limitations of battlefield medicine. They set me up to fail, Elena whispered. Those children died because Command wanted to prove I wasn't as good as my record suggested. Morrison's expression darkened with anger. That's unconscionable. Using patients as pawns in internal politics. The report was declassified 6 months ago, Chen said. Part of a larger investigation into Command decisions that prioritized career advancement over mission success. Several officers were court-martialed, but by then, you'd already left the military. You never saw the investigation results. Elena stared at the tablet, her carefully maintained composure finally cracking. Tears formed in her eyes as 3 years of guilt began shifting into 3 years of justified anger. I thought I failed them, she said. I thought those 3 children died because I wasn't good enough, wasn't fast enough, didn't make the right choices. You were sabotaged, Patterson said bluntly. You performed a miracle with deliberately insufficient resources, and Command documented your failure, while burying the context that explained why resources were insufficient. Morrison stood, walked to the window overlooking the hospital's emergency entrance. Dr. Vasquez, I'm offering you immediate advancement to senior resident status with full trauma specialization privileges. But more than that, I want you to help us develop a combat trauma training program here at Metropolitan General. Elena wiped her eyes, looking up at him. What kind of program? One that teaches civilian physicians the techniques you used this morning. The diagnostic approaches, the surgical methods, the triage protocols that combat medicine has refined through necessity. We have talented surgeons here, but none of them have experience with the kind of trauma patterns you've seen. I'm not sure I'm ready to teach, Elena said hesitantly. I came here to learn, not to lead. You've been teaching all morning, Chen interjected. Every time you explained your technique, every time you showed us how to read injury patterns differently. We learned more watching you operate on Captain Torres than we've learned in weeks of standard rotations. Patterson nodded agreement. Military and civilian medicine need to integrate better. Veterans like Torres end up in civilian hospitals with injury patterns most physicians don't recognize. You could bridge that gap, Elena. Teach us how to treat the unique complications that come from combat trauma. Elena looked at the tablet again, at the evidence that her guilt had been misplaced, that her perceived failure had actually been deliberate sabotage. The weight she'd carried for 3 years wasn't lifting entirely, but it was shifting, transforming from self-blame into anger at a system that had sacrificed patients to damage a surgeon who was too good. 3 conditions, she said finally. First, we establish a combat civilian medical exchange program. Military physicians transitioning to civilian practice get supported, not forced to hide their backgrounds like I did. Second, every resident learns battlefield triage and mass casualty protocols, because civilian disasters create the same impossible choices I faced in Kandahar, and our physicians should be prepared. Third, we partner with VA hospitals to treat veteran trauma cases with physicians who understand military medicine. Morrison didn't hesitate. Done. All 3 conditions accepted. When can you start officially? Elena stood, straightening to her full height. The hunched, invisible first-year resident was gone completely, replaced by Major Vasquez accepting a mission that mattered. I never stopped, Dr. Morrison. I just stopped letting you see who I really was. 6 weeks later, Metropolitan General's conference room buzzed with activity. Elena stood at the front, teaching a group of 20 residents the fundamentals of combat triage. On the screen behind her, she displayed injury patterns from actual field hospital cases, explaining how to read blast signatures and penetrating trauma that civilian medical training rarely encountered. Dr. Chen sat in the front row, taking detailed notes. Morrison observed from the back, watching his hospital transform under Elena's influence. Trauma response times had already improved 15%. Diagnostic accuracy on complex cases had increased measurably. And in the recovery ward upstairs, Captain Mark Torres walked the hallway under his own power, fully healed from surgery that had seemed impossible just weeks earlier. He would return to his family, return to his life, because a surgeon who'd been hiding in plain sight had finally stopped hiding and started showing everyone what different hands could accomplish when they stopped apologizing for being different. Part 8. Epilogue and Legacy. 8 weeks after Captain Torres' surgery, Elena Vasquez stood at the podium of the American College of Surgeons Regional Conference in downtown Chicago. The auditorium held 200 physicians from across the Midwest, all gathered to hear about Metropolitan General's revolutionary combat trauma integration program. Combat medicine isn't about war, Elena began, her voice steady and confident in ways it hadn't been 3 months earlier. It's about saving lives when everything is working against you, when resources are limited. Time is measured in seconds, and the difference between life and death comes down to recognizing patterns most physicians never encounter in civilian practice. Behind her, the presentation screen displayed statistics that told a remarkable story. Trauma response time at Metropolitan General had decreased by 34%. Diagnostic accuracy on complex injury patterns had improved by 41%. 47 physicians had completed the intensive combat trauma training program Elena developed, and 12 veteran patients with retained military injuries had received successful treatment using protocols that didn't exist 3 months ago. Dr. Morrison sat in the front row, introducing Elena with words that still felt surreal to hear. Major Dr. Elena Vasquez, who taught us that different doesn't mean wrong. It means better. Elena clicked to the next slide, showing the before and after comparison of Captain Torres' chest imaging. This patient arrived in our ED with retained IED fragments that had been migrating for 4 years. Standard cardiothoracic protocols would have required stopping his heart, increasing mortality risk by 40%. Instead, we used synchronized extraction techniques developed in field hospitals, working between heartbeats to remove fragments while maintaining cardiac function. The audience leaned forward, captivated. In the back row, Dr. Patterson watched with pride. Amy Chen sat beside him, taking notes for the paper they were co-authoring about military-civilian medical integration. But the real transformation isn't in the techniques, Elena continued. It's in understanding that medicine has many teachers. Combat zones teach efficiency and pattern recognition. Civilian hospitals teach comprehensive care and long-term outcomes. When we integrate those approaches instead of treating them as separate, we create something more powerful than either alone. She clicked to a slide showing Metropolitan General's new Veteran Trauma Center, opened just 2 weeks earlier with funding from Department of Defense partnerships and private healthcare grants. The facility bridged military and civilian medicine, staffed by physicians who understood both worlds. "We've trained 47 doctors in the past 2 months," Elena said. "But our goal isn't just local impact. The American Medical Association has approved our protocols for national implementation. The Department of Defense wants to establish similar programs at 20 trauma centers across the country, and the VA has requested our curriculum for training physicians who treat veterans transitioning from military to civilian healthcare." The presentation concluded with a video testimonial. Captain Torres appeared on screen, recovered and healthy, standing with his wife and 2 children. "Dr. Vasquez saved my life twice," Torres said to the camera. "Once in Kandahar under mortar fire with minimal equipment. Once in Chicago with every medical advantage available. The difference wasn't the equipment. It was her refusing to accept that death was inevitable. That's what combat medicine teaches. That's what every physician should learn." The auditorium erupted in applause. Elena stepped back from the podium, allowing herself a moment to absorb what had happened in 8 weeks. She'd gone from hiding her military background to becoming a national advocate for combat civilian medical integration, from first-year resident to program director, from someone carrying 3 years of guilt to someone teaching others how to carry the weight of impossible decisions. After the conference, hospital administrators and Department of Defense representatives surrounded her with offers. Chief of Trauma Surgery at Walter Reed, Director of National Combat Medicine Training for the AMA, Lead Consultant for Military-Civilian Healthcare Partnerships across 3 continents. Elena listened politely to each offer, then excused herself to check her phone. A text from Dr. Chen. "Patient in ED asking for you specifically. Former Marine, blast injuries. Local hospital doesn't know how to approach. Sound familiar?" Elena smiled, typing her response. "On my way. Prep Trauma Bay 3. She found Morrison in the conference hall, discussing her presentation with colleagues. "Dr. Morrison, I need to get back to the hospital. We have a veteran case." Morrison nodded, understanding. "The offers you're getting, Elena, any of them tempting?" Elena considered the question. 3 months ago, she would have said yes immediately, jumped at any chance to advance, to prove herself, to escape the weight of her past. But now, with Metropolitan General transformed into something that actually helped veterans like Torres, with residents learning from her daily, with a program that was changing how civilian medicine approached military trauma, the answer felt different. "I appreciate the recognition," she said carefully. "And I'll consult on the national programs. But my place is here, Dr. Morrison. Teaching residents that different backgrounds create better doctors. Treating veterans who need physicians who understand their injuries. Building something that matters more than career advancement." Morrison's expression showed understanding that went beyond professional respect. "When I told you your hands were different that first morning, I meant it as criticism. I was wrong. Those hands are different because they learned to save lives under impossible conditions. We're better because you stopped hiding them." Elena arrived at Metropolitan General 30 minutes later, still wearing her conference suit beneath a white coat that now read, "Dr. Elena Vasquez, MD, Director of Combat Trauma Medicine." The ED was controlled chaos, but she navigated it with confidence born from experience. Trauma Bay 3 held a 32-year-old former Marine with retained shrapnel near his spine. The attending physician looked relieved when Elena appeared. "Dr. Vasquez, this patient has fragments that shifted during a motorcycle accident. I'm not sure how to approach extraction without risking permanent paralysis." Elena studied the imaging, her trained eye reading patterns that 2 months of teaching hadn't yet fully transferred to civilian physicians. "I've seen this before. Similar case, Mosul, 2020. We'll need neurosurgery consult, but the approach uses modified field techniques to map fragment positions relative to nerve pathways." As she began explaining the procedure to the assembled team, Elena felt the same sense of purpose that had driven her through 7 years of deployment rotations. Not the adrenaline of combat medicine, but something steadier. The knowledge that her experience, her different hands, her refusal to accept impossible odds, they all served a purpose beyond just her survival. Dr. Chen joined the trauma bay, ready to assist. Young residents gathered in the observation gallery, watching Elena work with fascination that went beyond academic interest. They were witnessing something rare. A surgeon who bridged worlds, who taught them that expertise came from unexpected places, who proved that different wasn't a weakness to hide, but a strength to embrace. But Elena's story is just one among thousands. Across the country, other military physicians are transitioning to civilian practice, hiding their backgrounds because they fear judgment, suppressing skills that could save lives because they don't fit traditional medical training narratives. Veterans with complex combat injuries are struggling to find civilian doctors who understand their unique medical histories. These stories need to be heard. These physicians need support. These patients need advocates who understand that different medical experiences create different expertise, and both have value in healing the wounded. If you believe that medicine should embrace diversity of experience, that combat trauma training has lessons for civilian practice, that physicians like Elena Vasquez shouldn't have to hide who they are to be accepted, then this story matters to you. Share your thoughts in the comments below. Tell us about medical professionals you know who've bridged different worlds, who've brought unexpected expertise to traditional settings, who've proven that different hands can perform miracles. And if you want to hear more stories about emergency heroes who challenge assumptions, who save lives using unconventional wisdom, who prove that the most powerful innovations come from the most unexpected places, make sure you subscribe to Emergency Heroes Stories. We have an entire collection of tales about physicians, paramedics, and medical professionals who refuse to accept that impossible meant insurmountable. Stories of second chances, forbidden techniques, and medical bonds that defy conventional wisdom. Hit that subscribe button and ring the notification bell. Because somewhere right now, another physician is hiding skills that could save lives. Another veteran is struggling to find doctors who understand combat injuries. Another Elena Vasquez is waiting for permission to stop apologizing for being extraordinary. Their stories deserve to be told, and we'll be honored to have you with us when we share them. Until our paths cross again in the next tale, remember, those hands that seem different might just be exactly what medicine needs. Thank you for being here with us tonight.